Everybody else?
Just
Mauro,
what will the order be, Juan Carlos? Who goes next and who goes after that?
Yeah, sure. I can go at the end. I don't have any problem.
okay. What I'm going to do is I'll set the bar really low so everybody else will look good.
I doubt it.
Yeah, me too.
Keith, how are things with you?
Good, good.
You staying busy?
Yeah, well, we're not really doing anything much. We're starting up again soon, I guess.
Yeah.
Hope so.
Hopefully.
Yeah.
I'm just gonna put up my virtual background, so which has just disappeared actually.
Your video or
On my virtual back, have you seen this virtual background? So this is all right. No, I haven't got it here. Yeah, I got to copy it from my other PC. Hang on a sec.
all right. So David, there maybe the next week they will let us do some like outdoors exercises like running or bikes. I hope so.
Yeah. I'm telling you, there's no better place to be right now than outside. No safer place.
Yeah. Yeah, of course.
You keep some distance, but it's so important for mental sanity.
Yeah. They present that with the same name. Salud mental.
Oh yeah.
Yeah.
No. Yeah.
My background.
Oh, that was cool.
I like it. That's
Sorry, not the other day. This would be perfect.
Yeah, me too.
I need to go.
That's great.
Of course, we're gonna have it more, more boring.
I like it. Here, now that I'll show you my favorite one.
Let's see.
There we go.
Ah.
A nice gonioscopy picture.
Nice.
Yeah, looks cool too. So what do you think, Miriam?
I think
we can start the presentations of everyone, and then you can put the order.
Okay, perfect. Bueno, the presentation will be in Spanish for all our audience, and then you can proceed with your cases in English. Buenos días a todos, gracias por conectarse. Estamos terminando la semana de los webinars de glaucoma. Hoy tenemos invitados de lujo con casos terroríficos. Esta sesión de Oftalmo Horror Story se va a hacer, la vamos a continuar para que no se pierdan con nuevos casos terroríficos cada mes o cada 15 días, les vamos a ir avisando. Hoy tenemos con nosotros al doctor Keith Barton del Moorfield Site compartiendo un caso terrorífico, al doctor Davinder Gruber del Glaucoma Associated of Texas, al doctor Mauro Campos de la Escuela Paulista de Medicina y al doctor Juan Carlos Izquierdo de Oftalmo Salud. Welcome everybody, thank you for being here. We'll start first with Dr. Davinder, then with Dr. Keith Barton, and then Dr. Mauro and Dr. Juan Carlos. So I'm going to stop my sharing so you can start. There it is.
Okay. Let's see. All right, well, thank you. You guys, okay, can everybody see that?
Yeah,
Excellent. Okay.
looks good.
All right. Well, Juan Carlos, it's always a pleasure. Thank you again for hosting and making this happen, allowing us to stay engaged during these crazy times. And Mauro and Keith, great, let me join you guys, and I'm excited for this collaboration. I think it is nice to have things where we just have, instead of always showing the nice videos, show the tough cases, because I think that's the
Yeah, of
best way
course.
to learn. So I'm gonna try to, we all have a bunch of videos, and usually when there are complications, the video is not good quality. So this is really just more of a challenging case as opposed to like a horrible nightmare. But you'll see there'll be moments where you see the eye doing things you don't expect the eye to see. And this is a case of persistent hypotony. These are my disclosures, really none of which are pertinent. So this is a background. This is a gentleman who is 63, had bilateral fornix-based trabs in 1999. He then had a history of angle closure glaucoma advanced, so he's 0.95, his highest pressures known were in the 60s. Then he had a CRAO, eventually went on to get a cataract surgery in the left eye. The right eye, because of the CRAO and everything, he never really, it was a eye with very limited vision, never had any surgery on that, any glaucoma, cataract surgery. So his vision in the right eye is hand motion, left eye is 2100. And his pressure is about 8 in the right, 3 in the left. He has these pale cytonegative avascular blebs. And then he has this kind of, these irregular, macular folds consistent with hypotony in the left. Before the trabs, his nerves were about 0.95, 0.99, and with the hypotony, you can see some swelling of the optic nerve, and it makes the optic nerve look a little different. So his nerves are about 0.45, 0.5. He lives far away, and it's hard for him to get in. And I met him for the first time in 2009, and then I lost him to follow up for a while, and then he came back in 2018, and he's been stable. And this is what his maculas always look like. You see the classic macular folds, but it's his only eye. He has limited vision, but he's holding on to the limited vision he has, so he's always been hesitant to do anything about it. And then he comes to me last year and says, well, I'm moving away. I'm going to move down to the Texas-Mexico border, probably about 300, 400 miles away from really any good care. But he's like, before I leave, let me try, can you do something about the hypotony? I apologize, I don't have any pictures of this, but you'll see a picture from the surgery that's to come. So I did a bunch of, the way I do my compression sutures at the slit lamp is I do a bunch of horizontal X mattress type sutures over the bleb to kind of tamponize everything. And I got his pressure up from 3 to 8. His macular OCT didn't really change. His vision didn't change. And, I was going to leave him in there. Usually the sutures get absorbed by the eye. And then he comes back a couple months later and he has a little bit of inflammation in the eye. And there's a little area that's a bleb leak. And so we're concerned of a possible early blebitis. And so we put him on antibiotics and steroids. And just because of the plan of him, he needed to leave. He wants to leave town. He's selling his house. He's selling everything, and he wants to leave. So I wanted to, I didn't want to send him out with an eye like this. So I took him back to the operating room. I did what's called my partner, Ron Feldman, kind of termed plug and abandon, where you kind of shut down the bleb and place a tube. And so let's just walk through that video, and you can kind of see what it looks like. Really nice. So I'm going to pause it, and you can see here I did a bunch of these horizontal and vertical mattress sutures. I actually did mattress sutures twice, compression sutures to try to really tampon it. But you'll see he has a nice pale avascular bleb that's leaking, and so first thing I'm going to do is just take out the compression sutures. And anytime you see an eye like this, it just is going to bleed, and it's just going to bleed, and I'm going to start advancing it. But I want to take out all my compression sutures because I'm going to shut everything down. So first you have that down, and then I'm going to put my traction suture in to rotate the globe down, and now this is what you have. So you have this pale ischemic area that's prone to bleeding, and you have excessively scarred conjunctiva everywhere. So all this area over here is all pretty much scarred. You can see I have some distal good tissue, but all this is scarred. Here's that ring of steel. And I'm thinking of, okay, how am I going to close this? And so I start by just, doing a broad-based peritomy. And again, anytime you touch the eye like this, it's just going to bleed. So you want to make as wide of a peritomy as possible. So because I need to be able to have enough tissue, I'm going to put a tube in as well in the superior temporal quadrant. And this is his only eye. So I'm actually doing this topical. So I'm giving him some tetracaine. I'm going to give him a subtenon's block on the table. But because of the hypotony and everything, I didn't want to give him a block, a peribulbar block. So all this is topical right now. And what you need to do is first create a wide peritomy, and really find that bleb and dissect all the tissue out. And this is, I would say, here's the, when I think of nightmares, you don't expect to see. I don't like to see this much blood when I'm doing surgery. Makes you want to think you need to do a blood transfusion. So I'm just getting a nice broad peritomy, and then you can see right here. Can you guys see my pointer?
Yeah.
Okay, so you can see right here, there's a little defect right there. This is actually, the bleb is right here, but this is the opening right here. And what's important with these closures, the most essential thing is this step right here, cautery. You need to destroy all the epithelium. And what's nice about cautery also is you can use it to shrink down the tissue, to really shrink down that bleb and bring it down, because you need it to close. So I'm putting in some Helon, and you can see the only flow you're getting, it's kind of some diffuse flow, but it's really this area right here. And I have that ring of steel, and I have some scar tissue up here. So I want to close it down, and usually you need multiple ways of closing it down. So again, you get a broad dissection, break down all that scar tissue, and this is what you don't like to see, is all this blood. These are sick eyes that have been through a lot, and anything you do to them, they'll bleed. So right now I'm going to put some 9-0 nylon, and I'm just going to try to suture down that little area that I saw was was leaking. And then it's still going to be negative, but I'm being very careful, especially at the limbus, to destroy all the epithelial tissue. Otherwise, you're not going to get proper wound closure. And this is pseudoplast. So this is pericardial tissue that I'm going to use, and I secure it into place with 9-0 nylon. And you want a nice, tight, broad closure. Here, broad closure here, and then I'm going to trim it a little bit because it's coming over the limbus. But I'm going to just put a bunch of mattress sutures. You really need to make sure this is watertight. So I'm doing some mattress sutures, and then usually it's a little bit too long. The bleb is right here, so it doesn't need to be this back. So I'll trim it once I've attached it anteriorly. I'll trim it so that, because you want to be able to, again, you just want to close off all the borders. You want to make sure your anterior closure is watertight, your side closure watertight, because even if I've sutured all this tissue, it's still going to leak. And with this guy's, he doesn't have any conjunctiva. You're going to see later on, he really has no conjunctiva at all. So once I know I have a pretty tight, broad closure, I'm giving him more of a block on the table to make sure he's comfortable. A subtenon's block. And then I'm going to test the wound. I'm pumping up the eye, and I'm going to test the wound to make sure that it's watertight. And you want to pressurize the eye and make sure it holds the pressure. You can see it's still oozing a little bit, but this is a key thing to make sure you go and that's why I like pseudoplast for this situation, because it's very spongy. And now I'm just looking at the real estate. What do I have? Do I have enough conjunctiva to close things? But if I did this pressure is going to shoot back up. So I'm putting in a tube. So I'm creating a nice pocket. And then this is a 250 clear path. And what I've done, you'll see, is I've closed it off in a very specific way. because I know this guy does not have a lot of conjunctiva. So I'm not going to get a tight conjunctival closure. So I don't want the tube to open until I know everything is healed. I don't want to fenestrate. I don't want there to be any leak. So I want it completely tied off. So what I've done is, here's a ripcord. This is a 4.0 nylon ripcord, and I've tied it off with a, there, that's a better picture. It's a 4.0 nylon ripcord with a needle attached still. And then I've tied it off with a 7.0 proline suture. And I keep the wings long, just like you do when you're suturing a lens, so it lays flat against the conjunctiva and the sclera, and it won't perforate through later on. And so I put the tube in, suture it in place, and then what you do is I'm trimming it, and you really have no space at all here, but I'm going to go right next to my pericardial tissue, and enter it into the anterior chamber. And then I'm still in the U.S. You know, we like to still use a corneal patch graft. So here I've used two patches. I've used the pericardial tissue and the corneal patch graft. In truth, I could have used the other half of that pericardium to close it. But what I like about pericardium is this, is you just saw the pericardial tissue, when it swells, it gets pretty thick, and you can actually use it to anchor things to. So I'm actually suturing to keep this patch graft in place, I'm suturing it to the pericardium, as opposed to the sclera, which is a little scarred and maybe not the most competent. And then this is the next step, which is key, is I'm tucking my ripcord down below in the inferior fornix. So I leave the needle on, and this suture is in the tube, and if you pull that out, it'll open up the tube. But right now the tube is completely occluded. And so I really want that needle to come as far inferior as possible in the inferior fornix, and then you pull it through. And again, here you want to be careful not to pull it out, but you also want to make sure there's not a lot of slack. So I just leave it long, and I worry about it later. And once the needle is off the table, and then I pull it and make sure that I don't pull it out, but I also want to make sure there's no slack and it's tucked away against the wall of the eye. And I'm going to worry about trimming that later. And now, now we're in the mode of, this is, and I think we've all been in this situation where you're like, okay, now I'm ready to close the conjunctiva, and you just hope and pray that you have enough tissue to close. And there are a lot of different techniques to close. But in this situation, what I like is, here I'm trying to just reapproximate as much tissue as possible. And this is all, I'm mixing up between, I want something strong like some Vicryl to really be able to hold down some tension. And then I'm also going to use 9.0 nylon till it won't dissolve in time. So I'm going to mix up what I do based on how much tension I want to have. And you don't want a lot of tension on the conjunctiva because it's going to retract. But even if it does retract, it's not the end of the world, because with time, as long as your wounds are closed, everything will vascularize over, everything will epithelialize over, and it'll all heal. So here I'm just trying to put things back together, and I start off with the easy stuff first. Before I really want to avoid, I'm trying to delay this area, which I know is going to be the most difficult part. So here, I'm closing everything, and now I'm trying to just find enough conjunctiva to bring things back together. And we've described techniques of using a flap and all that stuff, but I think in this situation it's a lot easier to just try to, and he had enough conjunctiva that I was able to bring things enough. But these are all the little tricks to mobilize conjunctiva and bring it to the area. So I'm just taking it one step at a time. Again, here I'm using 9.0 nylon to close things because I don't want this part to dissolve at all, and just bringing that piece together, and now I have this huge open area. And you don't have to always close it entirely. And this is, I think, one of the big teaching points from this case is, do your best. He was monocular, so I'm not worried about motility restriction and double vision because he doesn't have vision in his other eye. But that's one thing you need to worry about if this patient had two good eyes. And what I like about pericardium is you can just, once you bring the tissue together, bring as much as you can without a lot of tension. So I'm bringing as much as I can together. And then at that time, I'm just going to start suturing this ridge to the pericardium, and I'm going to leave this big area exposed. And you can leave sclera exposed. You can leave everything exposed. So here, the most important thing is to, now I'm washing out all my Helon. I use Helon to form the eye. This is the moment of truth, right? Is now you're washing everything out, you're pumping up the eye, and you want to check all the wounds to make sure that you don't have a persistent bleb leak. And I'm telling you, if you don't take the time right now to fix this and get, you see this little area that's leaking, if you don't take the time to be meticulous and really really take your time to close it now, it's going to be a major pain in the future in the clinic when a patient comes in and they're leaking. So a lot of this stuff will scar down eventually, but if you have aqueous coming out, it won't heal. So, you know, I did as best as I could, which is that I put a bunch of sutures, 9-0 nylon over here, around here. But this tissue is very friable, and the more sutures you put in, the more it's going to tear. And so after I did that, I saw a little bit of a leak right here, and I knew I'm not going to be able to get it taken care of. So what I'm going to do is actually put tissue seal just over it. You need to keep the surface as dry as possible. And here I'm just throwing the kitchen sink at him, and then I'm closing it, not because I don't think it's okay to leave pericardium exposed, but because of this area right here that it was leaking, and I don't have the ability to close it down. I put in sutures, it's still leaking. So dry it up as much as possible, and then put a couple applications of tissue glue. And then here we have a case now where the bleb is closed down, it's watertight, the eye is pressurized. There's still going to be some oozing, and then I have this tube in place, because on the first day afterwards, the pressure could be 50 or the pressure could be 5. You have no idea what the pressure is going to be. You hope that it stays in the low teens, but you've shut down the whole bleb. It could be high, and so this is what it looked like. So the case was about an hour and a half, and I don't like hour and a half cases. Those are a pain. But you can see, you know, they didn't go all the way entirely, but you see some resolution and some normalization of his macular anatomy. But he still has some folds. But these are, you know, he had persistent hypotony for 10 years, so you usually don't go away. But I did see some improvement on the OCT. His vision improved. It started off at 2100, and now he's 2070, and that's pretty meaningful for someone's only eye. His pressure went from 3, eventually it was like, I think on post-op day 1, it was 6, then it went up to 8, and then 10, and then 12, and then 16, and then I put him on timolol, and then his pressure went back down to 6. And so I said, well, let's just use timolol once or twice a week. And I last saw him before all this this COVID craziness started, and he's doing well. But what's nice about this is he still has the ripcord in place. So if his pressure does go high, I can always open up the ripcord later. But I'm giving the whole tissue time to heal. And if you didn't tie it off with a ripcord and a proline, and you knew that in 4 to 5 weeks that tube is going to open, you're going to sweat things out, because you don't know what his eye is going to look like in 4 weeks. Is the tissue going to heal, or is it not going to heal? So I like the ripcord technique because it gives me absolute control over when the tube opens. And if his pressure stays in this low teen range on one drop, I'll leave the ripcord in for 2 years, 3 years, or forever. So, you know, what I like about this situation is the bleb is gone. So he can now move 300, 400 miles away, and I'm not worried about an infection. I can always restart medication if his pressure goes up. Compression sutures are good, but sometimes they can leak and lead to problems. And the key thing is sometimes you don't have enough conjunctiva, and it's okay to leave some bare sclera or bare pseudoplast, and it will eventually epithelialize over. And I'm sorry I don't have a post-op picture. I'm seeing him in a couple months. And what I'll do is, Juan Carlos, I'll take a picture and I'll send it to you so you can show it to everybody in the society to show what it looks like when everything heals. So I'm not sure if these are the nightmares you had in mind, but these are the kind of cases that you pull out some tricks, and with some planning and experience, I think we found we've been doing this for the last 15, 20 years, and we found that this technique has been a great way to handle these pale ischemic blebs.
Of course, thanks for sharing your nightmare. It was a nightmare when you was performing the surgery. I'm sure of that. Thank you very much.
My pleasure. All right.
And that implant was a non-valve AMET?
It's a New World Medical has come out with a new implant. They call it ClearPath, and it's a 250 and a 350. And what I like about the 250 ClearPath is that it's a little bit wider than an Ahmed, but it's more like a Maltino, but it's flexible. So it's a non-valve implant that's 250 millimeters squared, but it does not require muscle isolation. So it's more like a Maltino implant. You don't have to touch the muscles. You can in a single quadrant, but it's non-valved and it's flexible.
Looks good. Looks very good.
I think it's more cost effective and less expensive than some of the other implants out there.
Perfect. Perfect. Thanks, Daminer. Thanks, my friend.
Welcome.
It was really good.
Juan Carlos, may I ask some questions to Dave?
Yes.
Yeah, sure.
Yeah, I'm not a glaucoma guy, so if my questions look stupid, please excuse me.
I doubt it.
First is, I understood that because you had a ischemic bleb, so you thought about having hyperfiltration. Is that right?
Yes.
Do you have any experience with blood in the bleb? Does it work? I don't know. I have no experience. That's why I'm asking you.
Yeah, no, you mean putting blood in the bleb to slow it down? Yeah. No, I think that is a very commonly used technique. They call it a blood patch, where they would, you draw the blood and then you can inject blood in the subconjunctival space to try to induce some scar tissue. But then that's a good technique they used to use for these hyperfiltering blebs like you described. In this situation, what's tough is, let me show you a picture real quick. Let's see. So you see, in order to get scar tissue, you need to have blood vessels, and you need to have the ability to get cells and fibroblasts there to scar it down. And what you see in these kind of cases, can you guys see that video?
Yeah.
Okay.
Yeah, yes.
You see this central pale area. No matter what you do, unless you have blood vessels going into there, you're not going to be able to induce scar tissue. And so even blood won't close these down. And so, like, if you look here, sorry, let me see, I'm stuck. Yeah, if you look right here, this area, this is kind of what it looks like. And you have this big defect right here that where aqueous is leaving. And so blood won't be able to induce scar tissue in this situation. So I don't like to use blood if a patient has a bleb leak or if they have a pale bleb, and I think that risk for a blebitis. But say, for example, the conjunctiva is nice and healthy, but it's just overfiltering and the pressure is 3, but the tissue is healthy. Then sometimes if you do something to stir up inflammation, you can induce scar tissue.
I have to say, Devinder, my experience is that blood is very homeopathic in these situations. I remember injecting blood into one person's bleb, and I figured the way it works is you fill the anterior chamber up with blood right up to the bleb, and then you just watch the blood go all the way down. So once you've got an 8-ball hyphema, and then you go up into the bleb, then you've got enough blood to stop.
Yeah. No,
these are not procedures that I ever use for serious hypotomy. You know, maybe if you've got borderline, these kind of things work. But I just remember this guy literally filling the anterior chamber up with blood all the way.
No.
Wow. Yeah. Yeah. No. I agree. I think there are a lot of techniques, but the technique that I found really to help with hypotony is compression sutures. I've really had a good experience with compression sutures. But sometimes you have to do this.
Yeah, if you get them, I must say, I tend to do what you, I mean, I tend to open up and close, or up on, try and close the flap if you can, and if you can't, do exactly what you did with the, but I mean, sometimes what I do is put on pericardium and use that as a flap rather than closing completely and putting in a tube. But, you know, I mean, it depends on the situation, doesn't it?
Yeah, yeah. I like this because it was his only eye, and I knew he was going to leave, he's going to go far away and not come back. And so I wanted something that was the most predictable and most controlled.
Now, that's exactly what I would do in that situation. The only thing I was surprised at was the cornea and the pericardium.
You know, in the United States, we like to do the most expensive thing possible.
I'm going to make a side. I'm going to make a side swipe with that on my talk as well, a little bit, because of something. But anyway, that's a different thing. It's really very good. I mean, shall I start, or?
Yeah, sure. You can share your screen.
Because it kind of goes on from what Devinder's talked about. Let me find my screen sharing button. So actually get that. Okay, so
no.
you got the screen, yeah?
Yeah.
You see the screen. So what Devinder talked about was, you know, fixing the hypotony, but obviously sometimes fixing the hypotony isn't enough to fix the complication, like the choroidal hemorrhage, which is probably the worst complication you can get. And this is a video that I started to do but haven't posted because it's not finished yet. But I think we all dread choroidal hemorrhage. I mean, that's why we fix hypotony quickly. And there's two devastating complications, obviously, from hypotony. Serious maculopathy like this, which is really awful, or choroidal hemorrhage. And, you know, this is a patient 4 days after tube surgery, about 20 years ago, pressure very low. A few days later, with conservative treatment, you can see it's clearly hemorrhagic from the ultrasound with the opacification in it. But after tube revision, you get the pressure back up, but there's still a lot of hemorrhage there. And while it's essential to fix the hypotony, if you leave the hemorrhage here like this, the eye will lose all light perception, become fascicle. It's pretty much inevitable. So here's a case. This is a 69-year-old man who came to our emergency in 2014, 4 days after gardening, 4 days after travel. He was gardening and got acute eye pain. And when he actually came, you could see his choroid in the pupil. Now, we put in viscoelastic, so it's deeper now, but you can still see the choroidal hemorrhage behind the pupil a little bit. But basically, this guy had, like the previous ultrasound, large choroidal hemorrhage, except it was actually visible in his pupil with a flat chamber when he came to the emergency room. So my attitude to choroidal hemorrhages is obviously you got to fix the overdrainage trabeculectomy, as Devinder showed, or fix the tube. I don't tend to drain choroidal effusions unless they persist after the IOPs return to normal. But choroidal blood, if it's any size at all, needs to be drained. Now, obviously, you occasionally see people with very small choroidal hemorrhages, and you could physically drain them. You know that you've got to leave them. But it's the big ones that can really destroy the eye that you have to do something about. And so this guy that I just showed you that had the choroid in his pupil, and I put in viscoelastic, and a few days later it was deeper and the pressure was okay, but he really needed draining. Now, when I drain him, my main overwhelming objective is to get rid of all the blood. And the biggest failure that I've had in doing this is failure to get rid of all the blood. So I do something that I showed this at subspecialty day a few years ago, and they said, oh, this is terrible. You shouldn't go so far back. You should do it at the pars plana. But I actually go over the apex of the blood. So I look at ultrasound. They're usually inferior quadrants. I pressurize the eye with anterior chamber infusion. I enter the suprachoroidal space somewhere around the apex of the hemorrhage, according to B-scan. Now, obviously, you can't go exactly at the bottom of the eyeball where gravity takes the blood because the inferior rectus is in the way. So you've got to go infratemporally or infranasally. And I go literally about 11, 12 millimeters back from the limbus and open the conjunctiva, use some traction sutures to retract the tenons, and then do a V-shaped vent going in with the blade backwards so you don't not spearing the choroid, and then very, very gently, and then you get, whoa, and you can see from the color of that blood that is deoxygenated suprachoroidal blood, and you can see by the amount of it exactly what it is. And as I said before, you've got to keep the eye pressurized, so you've got an anterior chamber maintainer running all the time. And basically, you just sit here for a very long time, mopping it. And why do I do this myself? Because if I send this to retina, they end up with a vitrectomy, silicone oil, and physis. So, and that's not true of all the retina surgeons, but a lot of the retina surgeons will do a vitrectomy and will do silicone oil, and it's really may be necessary for certain types of hypotony choroidal hemorrhages, but it's not necessary for hypotony related ones just after glaucoma surgery. You really just need to drain the blood with as little interference as possible, and get as much of the blood out as possible without anything else being done. And that's why I make these small incisions. You got to wait 5 or 6. They say wait 7 days. This I think was 6 days, and I've got away with it 5 days. If you go earlier, you end up with clot. And if you make a big incision, you can end up with incarceration. So you make a small vent, and you just keep doing it and doing it and doing it. This is a cyclodialysis spatula, because what happens is when you get rid of the blood just over the vent, then the choroid's in opposition, so you can end up not draining everything. And this is all you do. Literally, you're just making a small vent, and you keep depressing and keep depressing and keep depressing and keep going until nothing comes out. And you can see still quite a lot coming out. And as I said before, the only mistake maybe not the only mistake I've ever made, the only big mistake I've ever made is not to be persistent enough. In other words, you drain what seems like a gallon of blood out of this very small eye, and the next day the hemorrhage is as big as it was to start with. And you can see why that might happen. You know, you get to the point where nothing's coming out spontaneously, and you use the cyclodialysis spatula, just very, very gentle depression, and still more comes out. And you've got to differentiate the dark blood from the blood from your. Obviously, there's a little bit of oxygenated blood around your wound, but you can easily tell the difference from the dark choroidal blood. And then what you do, you go to the other quadrant and do the same thing. And with a bit of luck, you've got most of it out. So if you started infratemporally, then go infranasally the next time. And with a bit of luck, if you've really been persistent, you've got rid of it all through the first quadrant. And again, while people like to go pars plana, I think that's quite good for effusions. For blood, you've really, really, really got to get rid of it all. And you just keep going. And almost invariably, there's much less in the second quadrant because you've hopefully been very persistent. So surgical technique, B-scan, obviously, to see where they are. I've never seen them, you know, they're predominantly inferior. It makes sense, you know, it's gravity. Good exposure, enter using the back of the blade. If it's an effusion, sure, go with the pars plana, but if it's blood, I go as close to the equator as I can to get as much of the blood as possible. And I always use an infusion to maintain the IOP. And keep going until there's nothing more coming out. And I use a little spatula to depress to make sure. And this guy, now this is interesting, and this is real show and tell, because this guy did really well. A month later, he was seeing 6.9. Now, nobody after that kind of hemorrhage ever sees 6.9, so this guy must have been very, very lucky. And you can see that's the down below where I didn't show it in the video, but I just glued the conjunctiva with Tisseal afterwards. I didn't suture the vents, I just left them open. and you can see there's a month later, it's just closed over. But this guy, although he had enormous choroidal hemorrhages, they must have been, you know, kissing without actually involving the macula, because when we drained the blood, his vision was 6/9 or 20/30, which really is not what you would expect with such large hemorrhages. Pressure was about 20, retina flat. As I say, this is not the typical result. He was a very, very lucky guy. Risk factors are obviously aphakia, myopia, but for us it's glaucoma, sudden decompression, and low IOP in myopes. The risk with the technique, retinal tear, retinal incarceration, well, I've not seen that, but then how many choroidal hemorrhages does even the busiest glaucoma surgeon ever drain in their lifetime? Well, not very many. I've done less than 10, probably about 5, something like that in 25 years. So I drain effusions if they're persistent after the IOP has been restored to double digits. But if I drain blood, well, it's nice to say you drain it immediately, but you never see the patients immediately, and it's always coagulated, so you have to wait a few days. Effusions pars plana, blood as close to the equator as possible, and don't send them to retina. Well, and this is a good example why. We're talking about the cornea and the pericardium here, Devinder, that this was like a US retina surgeon in Ophthalmology Times Europe talking about minimal techniques for suprachoroidal hemorrhage. So if surgical intervention becomes necessary, timing is critical. Yeah, it's important, but it's important to finish up with a vitrectomy. Minimally invasive or maximal reimbursement. Anyway, thanks for your attention. More videos can be seen if I ever get around to posting them.
Hey, that was very good, very good.
You didn't think there could be so much blood inside an eyeball, did you?
No. Thanks for sharing your nightmare, Keith. That was amazing. And I heard that you didn't close the vents, right?
No, you don't have to close the vents. In fact, it's probably better if you don't, because in theory they might drain a little bit. You know, if there's a little bit of blood still there, it might drain. It's like when you do vents for non-ophthalmos, you know, you don't close them afterwards.
Yeah, that's true. That's true. And also they make like a windows, scleral windows for sometimes in that cases, right?
That's basically all I'm doing.
Mm-hmm.
I got a very hard time from Marlene Moster when I did this at the AAO. She said, "You're always going over the pars plana. That's dangerous." I said, "Well, why'd you do that?" Then she said, "Well, it's because we get the residents to do it."
Keith, and how much you were working there?
What?
In that case, how much you were working there in that case?
Well, that was me. But you just, it's quite slow. You just have, I mean, I was sitting draining that blood for like 40 minutes or something, just pushing and pushing and pushing. So you have to do it very slowly. And it's tempting. I've seen presentations by retinal surgeons when they make a big incision and drain all, you know, it all comes out. But then you get choroid and retina stuck in the wounds, you know, where you really don't want that.
Yeah, I think that's a great point. You know what, I take a similar approach even with just serous detachments and serous suprachoroidal serous fluid, that, you know, you do a little bit, you drain, and then you wait, because then I feel like it gives it time to re-equilibrate, and then it pulls out. And sometimes I even like press on the eye in other areas to try to get it to pull. And then again, just like Keith showed, it was a great example. Then you do it again, you see another gush. And I think it's so important just to take your time and keep doing it and keep doing it and keep doing it until you don't get any more. But I love that. I love that approach.
Exactly. I mean, I thought, you know, there's times I thought I was done and then find I'm still there 30 minutes later. You know, you can be easily fooled into thinking you've got it. And the most frustrating thing on earth is to do a B scan the next day and still see this enormous dome.
And Keith, how many bends are you usually do? Like I saw that you did like 3. You usually do that?
Two. Infranasal and infratemporal. I usually try and guess which one's worse and go there first, you know, from the ultrasound. But it's always the inferior ones because of gravity. So I start at the biggest one, try and get everything out, and then with a bit of luck, when you go in for the second one, there's not much blood.
Perfect.
One question, Juan
Thank you very
Carlos.
much. Yeah, sure.
A quick question, Keith. I know that the name is not right for this, but you thought about having, let's say, explosive hemorrhage in these cases?
It's the same thing, yeah. It's what you call, I guess if you were doing an extracapsular cataract wound, and that would be an expulsive hemorrhage, it's coming out through the wound. I guess we don't call it expulsive as much anymore, because in that sense, after glaucoma surgery, there's no open wound, so it's not really expelling out through it. But yeah, it's the same thing. Yeah.
I wonder if you need like safety stitches before you go in the actual chamber.
Yeah, you need to. If this is from a tube when the pressure is too low, you need to fix the low pressure. You need to fix the overdraining trab. You need to fix the overdraining tube. This guy, however, had a pressure that was reasonable. We put in some viscoelastic. He was strange because he got this when he was gardening. And as far as we know, the trab wasn't done by me, it was done in another hospital. And as far as he knows, the pressure was always in double digits. So it's kind of odd. And he got this hemorrhage when he was gardening. We assumed the pressure was low. But whenever he came in, the first thing I did was inject some viscoelastic just to put everything back a bit. And the pressure after that stayed quite reasonable, teens, in fact, 20 after. So I never actually did anything to the trab to fix it. But that's unusual. Normally, you'd have to fix the trab or the tube and take the blood out.
Jesus. I'm glad I'm a refractive surgeon.
These are our nightmares. These are actually just our normal cases.
It's just every day.
It's not every day. Come on, guys. Don't say that.
Maximum I have is a free flap.
No. But let's see your nightmare, Mauro. Come on.
Let's see my nightmare. Okay, let me just share my computer with you. Okay, let's see. Can you see it?
Let me see. No, not yet.
Not yet. Let's try again. Now it's okay?
No.
No? Sure.
Yeah, now we can see it. Yeah.
Okay. This is the video moving?
Yes.
Perfect. So this is a pseudo exfoliation case. I'm not going to teach you about this. This patient had a white cataract, and of course the zonula was a little unstable. So we start, the way I like to do this, I do a deep groove to try to facilitate splitting the nucleus and taking them out, or phaco them out. Here I'm trying to push in a CTR in the bag, so helping with the instrument. I know that the lens is a little unstable, but I think it's worth trying to stabilize this lens or this bag before we keep on with the phaco machine. So I do this with a friend. We are always together in the OR, so we help each other in the happy and also in the sad moments. This is a little sad moment. As I push this, we are trying to put this big ring inside the bag. I never know what is the ideal size of this ring and how how far we can go with all these movements. But we are actually doing this using that fancy 3D microscope from Alcon, and we have this, stereoscopic glasses and looking at this structure, thinking that ingenuity can help us be a better surgeon. So this is also a 3D movie if you have a different resolution in your screen. What I'm doing is I'm trying to push in the ring and see if the lens is stable before I go back to my normal phaco surgery. I'm waiting for the lens to stabilize and see what I'm going to see. And you start to see in the very periphery of this eye, oh, look at what I'm seeing.
No.
All the deposits from the pseudo exfoliation material, as you can see there. I haven't seen this as, as severe as in this case. Of course, this is a 360 disease. It's not only in one of the quadrants. So what I need to do is deliver the baby. So I'm trying to push in this inside the eye. It's not a very delicate, approach, but I had no other option.
Yeah, of course.
So I decided to take out the lens and set up the eye for, to correct aphakia later on. That's my nightmare.
Wow. Thanks for sharing, Mauro. That was awful. Yeah, it usually happens, no? In PECs, actually, you don't know what's going to happen in the surgery.
Yeah, these are not easy cases, and when you need to use extra materials, such as an implant, to stabilize the bag, you know that the surgery is not going to be as easy as the other ones. I was just wondering the amount of deposits in the zonula. If you glaucoma guys have seen this much, I haven't seen before.
Oh yeah,
I've heard stories. I haven't, thankfully. What's interesting about pseudo-X is that it's seen all over the world. And I've heard stories. There's a pocket of pseudo-X in southern India, where patients present with angle closure glaucoma because all the zonulars are weak and the whole lens comes forward, and they go in to do the cataract surgery. They decompress the vitreous, and once they decompress the vitreous, the lens just falls back. So I've heard stories about that, but this was such an elegant way to just you see the problem and stopping it from going back, and you grab it and you're able to bring it out. Did you put an ACIOL, or did you suture a lens in, or how did you take care of it?
And actually, in pseudo exfoliation, I think it's better to go scleral approach.
Okay.
So I would not fixate in the iris, although I like the techniques with the anterior chamber lens in the back of the eye, like inverted worst lens. But in this case, I think because of the disease, I would do it in the sclera.
So do you come back later? Like you leave the eye alone and then come back a month?
Yeah, in this particular case, because we had no IOLs for fixating, so I had to go back and do it in a second stage.
How long do you usually wait?
You don't need to wait a lot.
Okay.
If the patient looks good in 1 or 2 days, maybe in 1 week or 2 weeks, I would do that. Actually, because it's not an easy surgery, sometimes you have some corneal edema in the first day, second day. I'm not sure if it would be better to wait more because of the macula and the possibility of having cystoid macular edema if you do too fast.
Yeah.
So, because I have, white hair, so I like to wait more.
Look this, Mauro. You were talking about pecs. Look how it looks, but inside it's like a monster house. You will see.
Oh, yes.
You can see a pecs there, like floating, but inside is very different. Look, it's.
Oh, yes. Gee.
That's a great video.
Thanks.
Actually, they
It's the pecs.
deposit over the ciliary body also. It's not only on the zonula. It's
Not only in the sonulas, it's everywhere. Yeah.
It's everywhere. And then it's harder when you do, if you ever do ECP, endocyclophotocoagulation.
That's true.
Exfoliation, it's a little bit more difficult because the material coats the ciliary body, and so it's harder to get those takes and the shrinkage.
Your patient looks worse than mine.
All right, so I will share some horror, also some nightmares. Let's see. All right, I will share you some cases that I had with a cosmetic iris implant. Dr. Choice actually did this in the 50s, but only for aniridia and traumatic cases. But from 2000, they start to perform this surgery for cosmetic reasons. And in this webpage, they put that don't have any limitation, any risk, or any foreign sensation like a contact lens. But from 2004, we saw some reports with a lot of complications, and I will show you this. This is my first case of a 28-year-old male that have an antecedent of this implant 1 year ago and came to the office with low visual acuity. As you can see, it's very blurry in the right eye because of the corneal decompensation. The left eye looks more clear, but he have like 66 in the right eye and 37 in the left eye with maximal therapy. And also I saw the gonioscopy and it was like a narrow angle. So this is the Visante, how looks the implant there. And the specular microscopy that was very pronounced in the right eye, that it can't count anything. And in the left eye, it was very low and in the 300s. Yeah, of course. So I performed first a surgery to reduce the IOP. At that time, I was putting the express shunt. And also it was my first case of this iris implant. So I prefer to do a glaucoma surgery first and then see how to take out that implant. So I make like a flap, as everyone knows there. I don't use this express shunt anymore because I had a few cases that I have to take it out and transform that to a trap. And then I put the express there. I close it. I put Ologen to manage also the bleb fibrosis. And then I close it. And then I have to take out the iris implant. Like I told you, it was my first case. So I put Helon below and above the implant to see if it's moved. And also I didn't know how attached it was to the angle, to the iris, you know. So I grab it and I try to take it out like little by little. And yeah, I had the same face like now. You can see the implant there. So look, the tips like are very sharp there. Look how was the eye. It have like a retraction of the iris. The pupil was very dilated and also with cataract. So at the end, he was with 12 and 13, but after 2 weeks, we performed a keratoplasty and a phaco also in the left eye. And after a month, he came to the office and he had 47 in the right eye. So I performed a phaco plus a drainage device. And he had a choroidal detachment, but solved with steroids. And at the end of the follow-up at 1 year, he was with very good pressure, but with a horrible vision, like you can see. This is the second case. It's a 26-year-old male that also have this antecedent 4 years ago. And he came with to the office with, as you can see in the left eye, with no vision. It was NPL with pressures above 50, maximal therapy. He have a drainage device, as you can see here. The tube is in touch with the cornea. And in the right eye, he has 14 with brimonidine and also with Diamox every 6 hours. And you can see here that this was very strange. They made like a cut in the cosmetic iris, like an iridectomy, right? Very strange. And here is the specular microscopy, very low in the 700. He's a young patient. So I talked to him, you know, I showed him the UVM. Look, the implant is in the angle. You have a retraction of the iris. This looks really bad. You have endothelial cell loss, and he disappears. And then he came back at 1 year and a half with a history of cyclophotocoagulation in the left eye and with pressure of 20 in his best eye. I showed him also the echography that he have already a retinal detachment in the left eye and starts to the cupping to grow in the right eye. So I told him, hey, come on, we have to take out this implant. This is the OCT and the HRT that we don't use it too much now. And he have a kind of damage there. And this is the photo of the optic nerve. But the question now is, what do you think? He take out the implant, yes or no? What do you think? Yes?
Is it loose?
I would take it out.
The question is,
what do you think about the
question is, can you get them out? Because you know, sometimes they're loose and sometimes they're completely embedded, I think. But having said that, I never tried to remove them. They just look very embedded. The ones I've seen look very embedded, so I never tried.
So I told him, come on, we have to take out the implant. And he didn't. He disappeared, and I never see him again. Never.
Jesus, man.
Well, I mean, some of them, like the one with the reduced, the one with the relatively clear cornea, you should take it out for sure, if you can. I know if he's disappeared.
But it's actually the patient doesn't want to remove it.
Well, if he's stupid enough to get it put in, maybe he's stupid enough to not want it removed.
Yes. Actually, they are improving the technique. Actually, now they are doing these iridectomies to try to avoid, let's say, a block in the aqueous or something.
But it's still going to
guys from Panama,
they're still going to screw up the cornea. I mean,
oh, definitely, yes.
Yeah. I mean, these are appalling. Yeah.
Are you guys seeing that? We see a couple of these in Miami, and in I think there may be some. I don't know. I think there's some people in at least close to the border in Texas, in Mexico that are doing these. But we see these come in to see us every every year we get a couple of these. They usually go to the cornea group, not our group, but these eyes always end up getting corneal failure, and glaucoma. Mauro, are you seeing these in Brazil as well?
Yes, let me, Juan Carlos, would you allow me to share my screen?
Yeah, we'll finish with this case.
Okay.
This is, I will show you the video also.
Oh, okay.
But yeah, she was with 21 and 40 at the end with maximal therapy. So the story of this girl is that she escaped from her house and went to other country to perform the surgery, and her mother didn't know. So I started to talk with them to take out the implant, to tell them about the risk of losing vision. And at the end, she accepted that, because I show her all the exams and also the endothelial cells that the losing is more pronounced in the left eye. So with a little of more experience, I went there with the micro scissors. I cut it.
Okay.
Like an IOL.
Okay.
And I take it out. But look, the difference of this implant from the other ones, that the tips are really sharp in this case. Look, that's why they attach like in the trabecular meshwork. They have like pigment dispersion, uveitis, glaucoma. So I saw the angle of this girl and it was open. So that's why I perform a cahook there.
But you not see some, Juan Carlos, where the angles, where it's just all embedded in the angle? No?
Sorry?
Are they always loose, or do you see some where it's completely embedded in the angle?
Always
yes,
loose.
By UVM.
I saw one where it was really fibrosed in, but I never took it out.
Ah, never. Okay.
No, what
I
key?
perform like a
The girl I saw was light perception in one eye and no light perception on the other. So
The ones we removed, they were all loose.
okay.
We never deal with fibros or
Never. Okay.
And these are the cases that I want to show you my nightmares. So about if you want, you can share your video too, because it is very interesting.
Yeah, let me.
I will. All right. It's free.
So who are you? Is there one or two centers doing these? Or
I think it's only one.
I heard
The one in
Panama
Panama?
and also other countries. Yeah.
Oh, yes.
Yeah.
I'm just showing how we improve the technique of removing it, because in the first case, we had no idea how to take this out. So we thought that these implants probably were fibrotic tissue in the anterior chamber or in the angle. So first we tried to remove like this. Like, let's try to push them out and see if they come out. They don't. So what we are doing now is much easier technique to remove them. We just fill in the anterior chamber with some viscoelastic, and we do almost exactly as Juan Carlos is doing. The only difference, we do 2 radial cuts instead of 1 single radial cut. And you go ahead, you just do like this. And they come out very, very easily. So if you want to do these radial cuts and take them out. That's it.
That's good too.
These are 2 bad cases.
Yeah, of course. Are really bad. Are very bad.
Normally we stay like
any
speechless for a few minutes when we do this. Perfect.
Well, thank you, everybody. I know I have a stomachache right now. Too much blood and too much. Thank you, everybody. Well, we have we're finished this session. Thank you for being here, for sharing your cases and your nightmares, Dr.
Thank you
Juan
very much.
Carlos.
Thank you.
Thank you, Kit. Thank you,
Thank you
Davinder,
all.
Mauro. Thank you very much for sharing not only good videos, just nightmares today.
Thank
Thank you
you.
very much.
It was a lot of fun.
Thank you. Bye bye.
Take care.
Gracias a todos. Ahora, como les recordamos, estamos teniendo 2 charlas a la semana.
Ajá.
El martes
Sí.
2 de junio tenemos al doctor Keith Barton con ciclodiálisis, para que no se lo pierdan. Vamos a tener un poquito más
Sí.
de pesadillas con él. Martes 2 de junio, un tema súper interesante del cual no se habla mucho, así que súper educativo.
Ajá.
Gracias a
Pero
todos.
es una pesadilla también, ¿no? Miren, es a
También,
nightmare
sí.
too. ¿Ah?
Sí, continúan las pesadillas. Muchas gracias a todos.
Thank you.
Gracias a todos, un
Gracias.
abrazo. Thank you very much. A big hug to everyone. Thank you for participate. Thank you very much.
Thank you.
I appreciate it.
Bye bye,
Thanks.
Juan Carlos.
Bye, Mauro.
Bye.
Bye, Kit.
Bye.
Bye, Davinder.
Bye-bye.
Thank you.
Bye, Juan Carlos. Bye, Mauro.
Bye.
Bye bye.